morning, everyone, and welcome to today's webinar hosted by PYA, New Medicare Reimbursement Opportunities for Rural Health Clinics. Before we get started with the webinar, I'd like to go over a few housekeeping items. As this event is for CPE credit, there are some additional steps that we will take in order to comply with NASPA request. In accordance with NASPA, attendees will be provided 3 polling questions throughout today's webinar. Responses are documented electronically. Attendees must respond to these polling questions within the allotted time in order to receive CPE credit for this course. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and the post-event survey must be submitted for proof of participation today. You will have the opportunity to submit questions to today's presenter by typing a message into the questions pane of the control panel. We'll collect these and address them during the Q&A session at the end of today's event if we have time. If not, our presenter will reach out to you directly. Now I'd like to welcome Lauren Farley with us today from PYA to kick things off. Welcome, Lauren.
Thank you. Good afternoon, everyone. My name is Lauren Farley. I'm the Business Development Coordinator here at PYA. We're delighted to have the opportunity to partner with MHA in an effort to support its member hospitals. PYA is the Platinum Education Underwriter of the Montana Hospital Association and a leading professional services firm providing expertise in healthcare, tax, management consulting, and audit and assurance. With that, I would like to introduce Martie Ross, Consulting Principal here at PYA. Welcome, Martie.
Thank you, Lauren, and good morning or good afternoon to everybody. Thank you for joining us today. By way of introduction, I am a healthcare consultant, and one area on which I focus is Medicare reimbursement, both regulatory and policy matters. And 2 of my interests in this area are an intersection of our topic today. I have spent a great deal of time both studying, writing, and presenting on Medicare policy around care management services, and also focusing on Medicare rural health policy. So today, our intersection is the new Medicare reimbursement opportunities for rural health clinics, specifically focused on care management services. So let's start our story by focusing first on Medicare policy that has developed in Part B around care management services. And as you know, in the last decade, CMS has been focused on pursuing new value-based reimbursement models within the Medicare program, be that shared savings, episodic payments, global budgets. And primarily that transition has been voluntary, though we have had some initial mandatory programs and promises from the Trump administration to continue to expand mandatory value-based models within the Medicare program. In fact, just yesterday, CMS published a request for information focused on enforcement activity relating to new value-based models. So certainly they are dug in and committed to this transition. But to facilitate this process, there's an appreciation in CMS that there need to be incentives within the fee-for-service structure that drive this transition to value-based reimbursement. That in fact we need to provide seed funding for physician practices and clinics and hospitals and all different types of providers as they consider how to better deliver care under the incentive structure of value-based reimbursement. And so since 2013, CMS has used the Medicare physician fee schedule reimbursement as a vehicle to incentivize those transitions by creating fee-for-service reimbursement for care management services. And this process started in 2013 when CMS introduced reimbursement for transitional care management. And truly, this was the first time CMS had developed a scheme for reimbursing services that occur outside the four walls of the clinic or the four walls of the hospital. And transitional care management was intended to provide support services for beneficiaries as they exit a hospital stay or a skilled nursing stay and return to home. And through the physician office, provide those support services to ease that transition to reduce the likelihood of readmission or complication. Really, in 2015, CMS made the most expansive move in this space by introducing chronic care management, which is strictly a non-face-to-face service delivered by clinical staff to individuals who suffer for two or more chronic conditions. We'll delve more deeply into that model of care as we progress in the webinar. But since 2015, CMS has continued to expand its reimbursement for different care management services, introducing behavioral health integration in 2018, as well as psychiatric collaborative care model. And just this year, made three significant moves in the care management space, including the introduction of interprofessional internet consultations, so physicians speaking with each other rather than having the patient going to a patient visit with a specialist, virtual check-ins, allowing a patient to communicate via a video platform with a provider, and thus again avoiding the face-to-face service. And then most significantly, the introduction of reimbursement for remote patient monitoring, which allows the use of a technology that transmits patient health information data from the home to the physician so that appropriate action can be taken to manage that patient's condition. Think, for example, of the patient with congestive heart failure. You want to monitor that individual's weight to identify any significant short-term weight gain, which may indicate retaining of fluid, which is indicative of potential an acute episode. If you have that remote monitoring technology, you're able to gather that data and thus better manage that patient. So CMS has certainly developed a full regimen of opportunity here for fee-for-service reimbursement for care management services. And in fact, now with the 2020 proposed Medicare physician fee schedule, they intend to, again, simplify some of these rules as well as expand reimbursement opportunities. So lots of activity in the Part B space. But as CMS has been doing this work, they remember the rural health clinic model and how can they create the incentives in rural communities to deliver these critical care management services. And thus CMS has secured reimbursement for rural health clinics around these four specific types of care management services, including transitional care management, chronic care management, and then again this year, behavioral health integration and psychiatric collaborative care model. And we're going to speak with about each of these in turn and what the billing rules are, as well as the opportunity for rural health clinics to secure this new reimbursement. Well, let's stop here and do a quick polling question.
Thank you, Marty. The first polling question is, an RHC may bill Medicare for remote patient monitoring services. True or false? Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back over to Marty.
And can we see those poll results, please? Okay. Currently, an RHC cannot bill Medicare for remote patient monitoring services. That reimbursement today is only available on the Part B Medicare physician fee schedule. CMS has not yet created a vehicle for RHCs to bill for a comparable service. However, as we'll talk through the chronic care management codes and the time that counts towards requirements to bill for that service, we'll discuss how remote patient monitoring can be utilized as a component of chronic care management services. And of course, we certainly hope that CMS will continue to expand these opportunities for rural health clinics. In fact, PYA submitted comments to the proposed 2020 Medicare Physician Fee Schedule and urged CMS to, in fact, provide reimbursement to RHCs that provide these critical services, given the unique ability of remote patient monitoring to serve rural patients and sort of eliminate those distance obstacles to receiving appropriate care. So let's dig in here, just a second. There we go. Let's start with Medicare reimbursement to RHCs for transitional care management. And the scope of this service is multi-pronged. It requires the billing provider to communicate with the patient within 3 business days of their discharge from an institutional care, either hospital inpatient or skilled nursing, to then perform a face-to-face visit within either 7 or 14 days, which is tied to the code that you bill for TCM, and then provide ongoing non-face-to-face care management services for that individual for 30 days post-discharge. There is no specific time requirement tied to TCM. The reimbursement for an RHC is based on the addition of the CPT code to the RHC claim, either 99495 if the individual is seen within 7 days, or 96 if they're seen within 14 days. The date of service listed for TCM is the date of the face-to-face visit. But here's the kicker. CMS has not provided additional reimbursement to incentivize RHCs to provide transitional care management. If you, in fact, submit the claim for TCM on the RHC claim form, you will not receive any additional reimbursement. You will be paid at your usual RHC encounter rate. So even though you've done the additional work of communicating with the patient following post-discharge and providing those non-face-to-face care management services, you're going to be paid the exact same as you would be for simply doing the face-to-face visit. So there's not a significant opportunity here for RHCs. Certainly in the best interest of the patient, certainly promotes controlling costs and ensuring proper recovery and return to functionality, but this is not an additional revenue opportunity for RHCs. Again, we routinely call this to CMS's attention, provide some additional kick reimbursement for this. In the Part B world, it's a significant kick up from just the face-to-face visit, but at this point, CMS has not moved. So let's talk secondly about chronic care management, where in fact there is a significant opportunity for rural health clinics. And here you bill this service, by including on the claim form the General Care Management G code G0511. CMS determines the payment rate of G0511 based on an average of national Part B rates for this particular set of codes listed here on the screen. And when you do that math, today in 2019, that national rate for CCM billed by an RHC is about $67. So compare that to what you're paid today in Montana for a Part B 99490, which is the standard CCM code on the Part B side, which is $43. So it's a significant $24 add-on reimbursement to a rural health clinic that is providing chronic care management services. Again, you can bill this on your RHC claim with either alone or with an RHC billable visit. Both will be paid. You can only bill 1 unit per month, regardless of the total amount of time spent, so long as you cross the 20-minute threshold. And then you'll report it with revenue code 052X. So let's break this down a little more. Let's talk about the billing rules for CCM. And again, these are derived from the rules CMS developed on the Medicare Physician Fee Schedule, and they simply have pulled them over to the reimbursement rules for RHC. So we're going to talk about who's eligible to receive this service, the rules regarding consent, We're going to work our way through the 5 specified capabilities for a provider furnishing CCM, and then finally focus in on the actual reimbursable service for care management. So starting with eligible beneficiaries, the beneficiary must have 2 or more chronic conditions. There is no definitive list of chronic conditions that CMS has made available. We generally refer to the CMS Chronic Condition Warehouse, which between probably 30 to 40 different chronic conditions identified there. In addition, the chronic conditions must be expected to last at least 12 months or until the patient's death, and that they must place the patient at significant risk of death, acute exacerbation of decompensation, or functional decline if not otherwise managed. CMS has not provided any vehicle for one to make this rather subjective determination. It is left to the provider who encourages the patient to receive CCM. The exclusions are relatively narrow. The individual cannot presently be receiving home health care or hospice supervision. Not that they can be receiving home health services, but they cannot also be receiving the professional service of home health supervision or hospice supervision furnished by a practitioner. Also, individuals that are receiving certain ESRD services under the global budget from any provider, they also are not eligible for CCM. So rather limited exclusions there from being able to receive the service. In addition to the eligibility requirements, the rules require that the CCM provider meet with the individual to discuss CCM as a part of a face-to-face visit if the beneficiary has not been seen in the practice in the last 12 months. So if Mrs. Jones was last seen 14 months ago, the doctor evaluates her condition, determines CCM would be appropriate and helpful. At that point, the physician would need to discuss with the patient the appropriateness of CCM and the opportunity. If the patient has been seen within the last 12 months, the service can be initiated without the required face-to-face visit, although consent will still be required. So let's talk about consent, which makes CCM unique. It is one of the handful of services where CMS actually requires the practitioner to secure consent to the particular service as a condition of reimbursement. Now, of course, we know that consent to care is universally required, but as a matter of common law, to overcome any objection of a tort of battery or the like, that we secure patient consent. But this is consent as a requirement for reimbursement. So here, the beneficiary consent must be secured prior to billing for the service. And it is the responsibility of the billing practitioner to document in the medical record the receipt of verbal consent. So this is not like a notice of privacy practices where you actually have to secure the patient's signature on the form. This is a recording of verbal consent. And if a beneficiary revokes consent, the practitioner cannot bill for CCM after the then current calendar month. The elements of consent, there are 4. So this is the information to be communicated by the practitioner to the beneficiary, and consent is then made by the beneficiary following the receipt of this information. First is a discussion of the nature of CCM services and how they are accessed, explaining that it is primarily a non-face-to-face service delivered by clinical staff. Secondly, that only one provider at a time can furnish CCM, and in fact, you will not be paid for having delivered CCM services if another provider with a more recent consent also bills for CCM for the same month. Third, the beneficiary must be informed that he or she can stop CCM services at any time by revoking consent, which again is effective at the end of the then current calendar month. And finally, specifically notifying the beneficiary that he or she will be responsible for the applicable copayment or deductible. So let's just take an example here to explain how these consent rules interface with the billing eligibility. So in our example, let's say the first RHC secures Jane's consent for CCM on January 2nd, while another RHC secures her consent on January 17th. Both of our RHCs are going to provide 20 minutes of care management services in both January and February. So which RHC will be reimbursed for services delivered in January? That would be RHC 1, because it has a current consent effective January 2nd, which remains effective through the end of that calendar month, January 31st. And then which RHC will be reimbursed for CCM services furnished to Jane in February? That would be RHC 2, which secured subsequent consent from the beneficiary, and RHC's 1 consent would terminate at the end of that month. So next, we've talked about who's eligible, how you secure consent. Let's talk about the specified capabilities. Again, unique in the Medicare billing world, that we are requiring the billing entity to be able to demonstrate certain capabilities to furnish the service as a condition of being able to submit a claim for these services. And in fact, when you submit the claim, you are in fact attesting to these capabilities. No, there isn't anything specifically on the claim form you have to check that says we are able to do A, B, C, and D, and E. Instead, you're simply representing to CMS, look, I'm submitting a claim for CCM, and by doing so, I'm representing that we in fact have these capabilities within the practice. So let's talk about each of these 5 in turn. And trust me, there are pages upon pages of Federal Register explanation around each of these capabilities. As CMS has developed up the billing rules for CCM, we'll condense these down to their core elements here. Starting with the use of a certified electronic health record. And in fact, CMS has now rewritten these rules 3 times since 2015. And here's where we are today. You must have the capability in your EHR to create a structured recording of patient demographic information, a patient's problem list, and their medications and medication allergies. And so if you are using a certified EHR, by definition, it should have the capabilities to do each of these 3 things. This is not a meaningful use standard. It is simply the utilization of a certified EHR. You must also be able to create a structured summary care record, that you are not required to use a specific tool to transmit that particular record, but within the EHR, you can generate the summary care record, which then is capable of being transmitted electronically. No specific requirement with regard to the manner that's accomplished, just that it's ready for transmission. Related to the use of a certified EHR is the generation of an electronic care plan, but here's the difference. If the standards for a certified EHR, CMS has never defined rules with regard to a care plan. In fact, care plans vary significantly based on a patient's condition, and thus CMS has not developed up specific rules on what should be an electronic care plan. So instead, here the requirement is simply that the practice delivering CCM services, the clinic delivering those services, maintains and regularly updates an electronic care plan for that beneficiary that's maintained electronically. There are 4 key components of that care plan. That it must be based on the patient's physical, mental, cognitive, psychosocial, functional, and environmental assessment of the beneficiary's needs. So it's a 360 view of that patient. It is an inventory of the resources and supports that that patient requires, addresses all health issues, not just the chronic conditions that qualify the individual for services, and it must be congruent with beneficiaries' choices and values. It should be thus a way of really managing the patient, not simply restricted to a particular service. So it is really intended to address all of their needs, not just manage them to a particular condition. Why this is important, why I'm highlighting this here, is CMS has now proposed in 2020 a new care management service called Principal Care Management. Principal care management is intended to focus on a specific condition that is not expected to continue over an extended period of time, but instead requires a direct intervention over a specific period of time. Take, for example, a patient who is undergoing cancer treatment. They are expected to recover and will end treatment in remission and recovery. So this is intended to create within the Part B fee schedule reimbursement for those services. Again, CMS has proposed principal care management on the Part B fee schedule and has not proposed an equivalent service reimbursable for rural health clinics at this point in time. And as you're starting to figure out, there's this typical delay between the point CMS stands up the reimbursement on Part B and then typically comes back and adds the RHC reimbursement 1 to 2 years later. And we'll hope that that will be the opportunity with principal care management as well. With regard to the care plan, and sorry for that little frolic and detour there, but let's go back to the care plan and the use of a technology tool to generate that care plan for CCM. The language is that you must electronically capture care plan information using some form of electronic technology tool or services to meet the care plan elements. Again, appreciating that EHR technology really doesn't support care planning at the time, and that they want broad practitioner flexibility and a range of tools that can be used to generate the care planning. Bottom line, a Word document meets this requirement, so long as it's not simply on a piece of paper in handwriting. You're going to meet the electronic technology requirement for the electronic care plan. Finally, CMS requires that there be a vehicle for the patient to access his or her care plan that must be capable of being shared electronically with the patient as well as other providers, be that secure messaging or participation in EHR. And alternatively, it can be provided on paper to the beneficiary if necessary and appropriate. So let's then talk about the third capability required for CCM, beneficiary access to care, and 3 specific requirements here. The clinic providing CCM must have a means for beneficiary to access a provider in the practice on a 24/7 basis to address acute or urgent care needs. So in fact, you have to have after-hours coverage available to your CCM patients. Secondly, the beneficiary must have the ability to secure successive routine appointments with a member of the care team, very similar to the RHC condition requirements there. And finally, there must be enhanced opportunities for beneficiary provider or caregiver provider communications, either by telephone or other asynchronous consultation messages such as secure messaging. So that it has to be more than simply those scheduled telephone calls, that you must have these other opportunities for interaction between the caregiver and the beneficiary. Fourth capability is with regard to transitions of care, that a clinic providing CCM must be able to assist in transitions by providing follow-up after an ER visit, the capability of transitional care management, coordinating referrals to other clinicians, and being able to share information about the patient with other clinicians as appropriate, both in terms of sharing that summary care record or the electronic care plan. Again, no specific manner of transmission required here. Note that this provide transitional care management is not the equivalent of the reimbursable service we discussed at the beginning of the webinar. This is simply that you are available and you have the capability to assist a patient as they transition out of an institutional level of care back to home or another level of care, but not necessarily meet the requirements specifically, i.e. contact within 3 days, 7 days, face-to-face visit. No, it's simply meaning that you have the ability to support the transition, not actually provide the reimbursable service. The final capability listed for CCM providers is coordination of care, and having within the practice, the clinic, the ability to coordinate home and community-based clinical services and being able to meet the beneficiary's psychosocial needs and functional deficits. And that thus means there's coordination with home health or hospice, there's coordination with outpatient therapies, DME suppliers, and then also addressing those social determinants by coordinating transportation or providing nutritional support, such as Meals on Wheels for an individual. So you can pull in those community resources as available to assist the patient receiving CCM. That does not prevent you from providing CCM if those services are not available in your communities, as is often the case with small rural communities that are served by RHCs. Instead, that to the extent those services are available, that you as the CCM provider serve as that coordinator in support of the patient. And again, to demonstrate that you've met this capability, the CMS would require that these types of communication be captured and documented in the medical record. So again, remember, we've just talked through those 5 capabilities. These are demonstrated competencies for CCM providers. That this, in fact, is demonstrating to CMS that you have developed infrastructure, you have appropriately trained staff, you understand resources available in the community, that you are appropriate, in fact, to serve as the care manager for these beneficiaries that have a higher level of need. So finally, let's talk about the actual care management services. So we've talked about patient eligibility, we've talked about the consent requirement, we've talked about the capabilities within the practice. Now let's talk about the actual service delivery that generates a reimbursable event, and that's the care management services. These are furnished by clinical staff under general supervision, meaning there's no requirement that a physician or non-physician practitioner be physically present at the time the services are being delivered by clinical staff. By clinical staff, very broad definition taken from the CPT book, an individual that is considered qualified to deliver the level of service by the billing practitioner. You would need to have your RHC medical staff determine that, yes, this RN or this LPN or this LSCSW or this MA even is qualified to provide these services. It must in fact be a clinical staff member. It would not be appropriate to simply have the administrative staff like the receptionist performing telephone calls and counting that as part of the care management service. The types of things that these care managers provide, the services in support of the individual, CMS sort of provides a non-exclusive list of examples. So you would expect the care manager to work with the beneficiary to complete a medication reconciliation or provide oversight of the beneficiary's self-management of medications. They're going to make sure that the beneficiary is receiving all of the recommended preventative services. So reviewing, do you have your flu shot? Have you had your pneumonia shot? Have you done your annual wellness visit? Sort of going through that with the beneficiary to ensure those preventative services are being provided. And then just providing general monitoring of the beneficiary's condition, checking in on physical complaints, how they're feeling, if they're interacting, are they receiving support services they need, all of those types of activities. Again, CMS is not prescriptive here. Instead, they're providing by example, appreciating that different beneficiaries in different communities are going to require a very different range of services to support them as they manage and live with their chronic condition and attempting to avoid that acute episode. And in terms of documentation in the medical record, because as we all know, if it isn't documented, it didn't happen. CMS has advised that the clinical staff providing the service should identify the date and the total time spent furnishing the service. The gold standard of any time-based codes is listing the start and stop time. That's not required. You do need to have the total amount of time recorded. Stop time is simply a very reliable way of demonstrating that you have provided the 20 minutes of services. You would list the name of the individual providing the service with their credentials, and then a very brief description of the interaction with the beneficiary over that period of time. Now, as we've referenced before, CCM is a time-based code. It requires a minimum of 20 minutes of service to the beneficiary in a calendar month. It can be provided over several days. So you could have 5 minutes here, 7 minutes here, 8 minutes here, 10 minutes here. Each would be recorded as a separate entry in the medical record. You cannot carry time over from one month to another. So if you do 25 minutes worth of service in February, you don't start March 5 minutes up. You start from 0 in March. And there is no additional reimbursement if you spend 20 minutes, if you spend 40 minutes, if you spend 60 minutes. The RHC CCM code, there's only one level of reimbursement, that's $67. Compare on the fee schedule, the Medicare physician fee schedule, the Part B benefit, there is differentiation in payment based on whether you provide 20 minutes or 60 minutes. They are two different levels of reimbursement, not here. It's just 20 minutes plus to whatever it requires. Again, this is services delivered typically by clinical staff under the supervision of a physician or mid-level. General supervision, again, no physical presence requirement. Nowhere is there a requirement that supervising provider sign notes. It's not necessary that you have a note by note by note review. Simply general supervision is really that practitioner verifies the individual's qualifications, their competency, their experience to deliver the level of service, and of course providing support as requested to that clinical staff member. You can aggregate time, but you cannot round up. If you end up at the end of the month with 19 minutes and 35 seconds, that is not enough to bill CCM. You may have multiple individuals providing CCM. Care manager A may provide services, care manager B provides services 2 days later. You can count that time. You can add it together to get to your 20 minutes, but you can't double count time for 2 staff members providing services at the same time. CMS has made that very clear that only one person at a time can be counted. CMS has not addressed the issue of whether you can count time delivering services to multiple individuals at the same time. For example, CCM is a vehicle to secure reimbursement for patient education or use of evidence-based programs to work with your patients. So you could have a circumstance where you'd have potentially 3 or 4 or 5 individuals and the care manager working with all of them at the same time, say by telephone conference or by in-person meeting. That time would count for each of those individuals. CMS has not specifically, even though asked the question, they have not specifically said that is not permissible. And thus, at this point in time, you can count the same time providing services to multiple individuals by the same clinical staff member. Note there, I made reference to a face-to-face encounter. CMS has clarified that, yes, face-to-face time with a beneficiary that does not count toward another service can be included in CCM time. So if you're going to use that time in any other way to qualify for an RHC service different from CCM, you cannot count that. But if it is a face-to-face encounter that does not otherwise qualify, you can include that within the 20 minutes. You also can include physician time and non-physician practitioner time. Again, if it's not otherwise counted towards a reimbursable service, that they can in fact use CCM to capture that time as well. Also, finally, and I made reference to this earlier, before CMS created the reimbursement for remote patient monitoring on Part B, it was very common to use CCM as a way to gain reimbursement for providing remote patient monitoring services. So that time spent reviewing data being received remotely by the physician practice and deciding on the appropriate intervention, that was time that was counted for CCM purposes. And of course now, even though RHCs cannot submit claims and receive reimbursement for remote patient monitoring, that time they spend in support of remote patient monitoring would in fact count towards your 20 minutes for CCM purposes. So that gets us to our next polling question.
Thank you, Martie. The second polling question is If two clinical staff members discussing a CCM patient's transportation needs can count towards the required 20 minutes, please select one, true or false. Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back to Martie.
Let's see the results, please. It's a trick question. I have to be honest with you. And just an illustration of how not everything is black and white when it comes to CCM. One of the individual's time could count. So if it's two nurses discussing, I need to secure transportation for this patient, do you have options? And the other is suggesting, well, here's 3 or 4 different services I've used previously, maybe this is an option. In that conversation, only one of the clinical staff members' time counts, not both. You can't add the two together. So 5 minutes here, 5 minutes here, no. It's only going to be one of the staff members' time can count towards CCM. Just to illustrate that CMS has provided a great deal of guidance around CCM, trying to identify these different types of issues. One must be attentive to those matters as they bill for CCM. There we go. Let's talk a bit about how do you make this practical? Because in an RHC, everyone's already wearing 3 or 4 hats. And where are you going to identify the clinical staff who would also be delivering CCM? And in recognition of that, and that's not unique to RHC, small physician practices face the same issues. CMS has identified that you can have shared staffing arrangements, thus that allowing an RHC through a contractual relationship with a third party deliver CCM. And thus, for example, you would have a staffing company that has qualified clinical staff members who can do that care management services. They can develop up the care plan, work with the patient across that care plan, document in the practice's EHR those services, and thus enable the RHC to bill for those services. You also have accountable care organizations, clinically integrated networks that are managing patient populations, centralizing a team of care managers who service multiple participants in that organization and deliver care management services to identified high-risk beneficiaries. The key there is having a sufficient degree of integration, which typically if the centralized team of care managers has access into the practice EHR as a user, that generally is considered sufficient level of integration. And really you have to make sure that you've crossed all your T's and dotted all your I's, that within that relationship between the clinic and this third-party provider of CCM services, that you've ensured that you meet all the capabilities. So it may be that, yes, that third party is providing the 20 minutes of non-face-to-face services, but it's relying on the clinic's ability to provide continuity of care or to provide 24/7 access or call coverage. And so the two together meet all of the requirements for delivering CCM. And you are seeing a number of these arrangements, particularly in rural areas, as they look to leverage resources to provide care management services to their populations. And I'll give you an example as an illustration of the power of CCM to impact total cost of care. So we work with a rural ACO here in Kansas. I'm based in Kansas City. This rural ACO has been stood up since about 2015. They participate in the Medicare Shared Savings Program. Currently, the participants cover about 36 rural communities. And I think there are something around the neighborhood of 150 different RHC connotations within this ACO. They have a centralized care management team, about 10 FTEs at this point in time. They bill services under the RHC code, so they get the $67 reimbursement. And they have, in fact, realized revenue sufficient to fund the delivery of services. So it is self-perpetuating just in the delivery of care management services. But because this is a Medicare Shared Savings Program ACO, they receive access to claims data. When you're in the MSSP, you're attributed beneficiaries. You receive both historical Part A, Part B claims data, as well as a monthly feed of that data. So you, in fact, know, regardless of the provider, the total cost of care for your attributed beneficiaries. And so we were able to use that data to track the impact of chronic care management services on beneficiaries' total cost of care. So what we did is we identified all of the beneficiaries who initiated CCM services in 2016 or 2017. And that gave us a universe of about 1,500 beneficiaries. And we said, let's look at all of their Part A, Part B claims data for services they received in 2017, and let's compare it to the total for what they received in 2018. So this is this isn't a control sample. This is the same group of individuals, the difference being that they received CCM. So they initiated in 2017 and then continued it into 2018. And we said, let's calculate the impact that had on total cost of care. So, and normalized, so we were truly comparing apples to apples. So here are the results from that analysis. And at the bottom line is that the total cost of care for our 1,500 individuals reduced by 22% between 2017 and 2018. That's the impact of the intervention. What you see here is the breakdown on particular expenditures, and noticing a significant movement in inpatient services, in post-acute care services, that being able to work with these patients and manage their conditions is reducing their need for healthcare services and thus reducing total cost of care. So we see this as very clear indication that when performed well, when focusing on high cost individuals, that CCM really moves the needle. This population, these are rough numbers, but in 2017, the average cost of care for these 1,500 individuals was about $25,000. In 2018, it was under $20,000. So that 22% movement in total cost of care. For this ACO, their actual benchmark, their average total cost of care for their entire attributed beneficiaries was about $12,500. So these patients are costing twice as much as the average patient. With this intervention of CCM, you're seeing a significant movement. So that's why CMS is incentivizing you with fee-for-service reimbursement to provide these services, because they know the actual impact is to reduce total cost of care, meaning you'll be better prepared to succeed under new value-based payment models. So let's switch gears from CCM and talk about its complementary service, behavioral health integration. This is a very close cousin of CCM, but with different rules. This is providing care management services for individuals with any behavioral health or psychiatric condition, including substance abuse. So this is not two chronic conditions. This is just individuals that have a diagnosis of behavioral health or psychiatric condition, including substance abuse. We do apply the same rules as CCM with regard to initiating visit, consent, and that 20 minutes of care, 20 minutes or more of care management services. The difference here are there are a different set of capabilities required for behavioral health integration. Otherwise, you use the same billing rules. You're using GO 511 as the billing code for behavioral health integration. If you are providing this service, it involves an initial assessment and then follow-up and monitoring of that patient, including the use of validated rating scales like depression scales, for example. It includes behavioral health care planning related to behavioral and psychiatric health problems, including a revision of those plans for individuals not progressing well. It involves facilitating and coordinating treatment for an individual and ensuring continuity of care. The key here is these are services, these 20 minutes of care management services focused on behavioral health issues are being furnished by clinical staff. And so it is intended to be an extender of limited behavioral health resources within a community, but being able to focus in on the needs of that individual to help them better manage the condition. It is a gap filler. It's the best way of looking at behavioral health integration. And it is simply very much like CCM, except you have the lesser requirements with regard to capabilities. You don't see here the care plan requirement. Instead, it's just a general planning requirement here in this particular service. So all of this said, does it make sense to provide CCM? We've talked about the impact on total cost of care and definitely the benefit there, but can you make this cash flow within your own rural health clinic? Let the back of the napkin math here, and it's nothing more than that. Assuming you have a clinical staff member who is going to furnish CCM services, and let's say they cover 100 beneficiaries per month. What that would generate at $67 per beneficiary over 100 beneficiaries across 12 months, that's generating $80,000 potential revenue. Now, we'll assume that you've got a bill for those services, and we'll take that as a 10% billing cost. And you probably have issues with collection, in part because these codes are still subject to copay and deductibles. They still have to pay their 20% copay and deductible. So we'll say it's a 15% collection revenue. So net revenue, if you bill for these services, is about $60,000. So the question you have to face in your rural health clinic is, can we secure the clinical staff and provide them salary and benefits and their access to an EHR within that net revenue number? Note here, as you look at this map, that 100 beneficiaries per care manager is a very low number. Usually the target within a well-organized care management program is closer to 150. But appreciating that with the limitations of RHCs, with the other responsibilities that clinical staff may be responsible for, we think 100 is a pretty good rule of thumb in evaluating the opportunity here for revenue. And we have our last polling question here.
Thank you, Martie. The third polling question is an RHC required to charge the beneficiary the 20% copayment for care management services? Please select one. No, they are preventative services. Medicare covers 100%. No, if a copayment waiver is consistent with RHC's policy, or yes, no matter what. Remember, you must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now I'll hand it back to Martie.
And can we see the poll results, please? Excellent. If an individual has supplemental coverage, Medicare supplemental coverage, that supplemental will cover the $12 copay, well, it's about $12.50, for CCM services billed by an RHC. Otherwise, if the individual does not have supplemental, that's an out-of-pocket expense. And true experience has taught that is, in fact, an obstacle to individuals accepting and engaging in chronic care management services. And CMS has been asked repeatedly to waive the copayment requirement. And CMS has said repeatedly that it does not have the statutory authority to do so. CMS does not identify care management as a preventative service, and thus the exception that provides 100% coverage of preventative services for Medicare beneficiaries does not apply. However, as is the case with any service furnished by an RHC, if you have a properly developed financial assistance policy and an individual qualifies for financial assistance, which may include waivers of copays or deductibles, that can be applied to excuse the copay or deductible. to protect yourself, you have to certainly be certain that that policy is appropriately documented and the application of the policy to the individual has been appropriate. But otherwise, absent the application of a financial assistance policy, you are expected by CMS to bill the copay and deductible as appropriate for an individual receiving CCM services. And again, appreciating that it has truly been an obstacle to the delivery of the service, to the point now that there has actually been legislation proposed in Congress to eliminate the copay requirement for CCM, but we'll see if it makes it through the gamut in Washington. Sorry for the technical difficulties there. Got to press the right button. Finally, let's close out on the psychiatric collaborative care model, which is an expanded version of these gap filler behavioral health services. This is a different G code than the care management code. This is G05112. The payment here, again, is an average of Part B payment rates. At the rate for 2019 currently is just shy of $146. Again, you bill it on a claim with or without an RHC billable visit, once a month only, just like CCM. And again, you report with revenue code 052X. Excuse me. So what are the requirements for billing this? Well, first is that you have to have a team. It is a three-part team that delivers this collaborative care model. You have to have the RHC primary care practitioner, and then that person is assisted on the ground by a behavioral health care manager. So this is an individual who is physically present or aligned with the rural health clinic. At least a bachelor's level training in behavioral health or clinical experience. So this cannot just be the MA that's providing CCM. This needs to be an individual who either has been formally trained in behavioral health or has had extensive clinical experience working with behavioral health issues. Otherwise, the types of services they're providing are going to very closely overlap with what's being provided with behavioral health integration. So it is that planning with the patient, working with the patient, assessing the patient, coordinating care for the patient. And then, importantly, working and engaging with the psychiatric consultant, who is the third member of our team, is that we have the medical professional trained in psychiatry who's qualified to prescribe the full range of medications. That's the person who can qualify as our psychiatric consultant. This is by contract. So this is a contractual relationship with the RHC, with this psychiatric consultant, who is truly just providing consultative services, not direct patient care services. So that psychiatric consultant is performing regular reviews of the clinical status of those beneficiaries who are receiving these services. They consult with that primary care practitioner as appropriate, as well as the behavioral health care manager, and then they facilitate referrals as necessary and appropriate. Again, this is intended to be an extender to bring behavioral health services into shortage areas, such as rural communities, and provide the service. And it has a significantly higher reimbursement rate, nearly 3 times as much, because the appreciation that there will need to be a contractual relationship with the psychiatrist, and there will be dollars, a percentage of that reimbursement the RHC is receiving is certainly flowing back over to the psychiatrist to compensate them for their time. The time requirements are also significantly greater. To bill for this, same rules with regard to initiating visit and consent, it's the time that differs. In the first month you provide the service, you have to be at least 70 minutes, and it's all 3. You add up the time from all 3 of those team members, and then in subsequent months, it's 60 minutes. And there, again, you can't be separately billing for time for that practitioner. It has to be standalone time that then can be billed as part of that collaborative care model. We've already done that. Let's skip that slide. One final note here to cover as we are closing up on our hour is, what do we do with cost reporting? Since we're in an RHC environment, the costs of providing these care management services are reportable costs that must be included in your RHC cost report. You report them per CMS guidance under other than RHC services section of the cost report. And the good note that these numbers are not used in determining the RHC error rate. in fact, it stands alone, but CMS does want this data reported for tracking purposes to appreciate the investment the RHCs are making into providing care management services. So we have made it to the end of our time here together. I appreciate you spending the hour with us talking about these new opportunities for not only RHCs to generate new revenue, but really to develop those critical competencies for value-based reimbursement. And if you all do have questions, please reach out to the chat feature. We'll make sure that we get back with you. So again, thank you for your time today.
Thank you, Martie. We'd like to thank our presenter, Martie Ross. If you have any questions, her presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise, or to subscribe to receive our PYA Insights. Please remember to stay on the line once the webinar disconnects to complete a short survey for CPE credit. On behalf of PYA and MHA, thank you for joining us and have a great rest of your day.